This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be lab data interpretation. This is going to be part 2. We're going to start this off with coagulation tests. Coagulation tests measure your body's ability to clot, as well as how long it takes for your body to clot. And there's 2 pathways that we're going to kind of review here. There's an extrinsic pathway and an intrinsic pathway. The extrinsic pathway is caused from outside or external or tissue damage. It involves platelet aggregation, chemicals that would activate the common pathway. Once the common pathway is activated, then we start forming the thrombus. And then once the thrombus forms, calcium is introduced and this fibrinogen polymer is going to occur, and this is the clot until repair actually occurs to the tissue. Now, talking about this, fibrinolysis, or the busting down of a clot, any time that we activate plasminogen to form the active form of plasmin, the clot will break down. It's like a self-destruct mechanism built inside of it. So this is the extrinsic pathway to form the common pathway here, and this is caused from tissue damage. Extrinsic. Intrinsic, with an I, starts off with platelet damage and the platelet's ability to aggregate or stick, and it still formulates the common pathway. So in either case, whether it be extrinsic or intrinsic, this common pathway is formed. And if we'll notice here, calcium is a very big part of this. And so whenever calcium is added to these enzymes that are forming and developing the clot, prothrombin to thrombin, fibrinogen to fibrin, but all of these essentially formulate what we know as a clot. And then again, last time, fibrinolysis, whenever this occurs, this would be the breaking down of the clot, plasminogen to form the active form of plasmin. Alright, so prothrombin time, or PT. Significance of this measures the effectiveness of Coumadin and anticoagulants. And what prothrombin time does is it is measured in seconds here. I'll read you a little bit of my notes here. Prothrombin time is a measure of the integrity of the extrinsic and final common pathways of the coagulation cascade. This consists of tissue factors 7, 2, prothrombin, 5, and 10, and fibrinogen. So this measures extrinsic. It is valued 11.2 to 13.2 seconds in both male and female. And high values on this, and just a common sense approach here, why would the seconds be longer before you actively made prothrombin? And the answer would be is your liver's in failure, you do not have enough clotting factor, your vitamin K, which is the prothrombin, or the actual formulation of the clots, is very vitamin K dependent. So you have a vitamin K deficiency, or you've used everything all up. You're in DIC, or disseminated intravascular coagulation. And DIC is, for whatever the reason, whatever the cascade, because there's a multitude of them, you start making multiple little clots. Now, in that same fact, you've used all of your clotting capability on these little bitty clots. So, in the overall big scheme of things, systemically, you could bleed to death. But all of these clots are free floating around your vascular system. Now, the problem with it is anything that would filter blood now becomes clogged. Treatment for this would be vitamin K. and that would actually assist the common pathway that we saw in the previous slide. Partial Thromboplastin Time, or PTT. Significance of this detects coagulation disorders in the intrinsic pathway of the coagulation cascade, and that's what this does. The last one, the PT, looks at the extrinsic, and that would be from tissue damage. This one looks at the intrinsic from the platelets perspective. Normal values 22.1 to 34.1 seconds. High value on this would be too much heparin on board. Low values are not clinically significant. Treatment of this is decrease the heparin dose, or protamine. Now, protamine is a antidote for overdose of heparin, 1 to 1.5 milligrams per standard unit of heparin that we think that we've overdosed them. Treatment also could be fresh frozen plasma, because this would actually have our coags in it. INR, or International Normalization Ratio, reports the PT in standard form, and this is prothrombin, compares against the control. In healthy patients not receiving anticoagulants, INRs are about 1. They are 1 times the reference value. My apologies for the pause. They are 1 times the reference value. A patient receiving warfarin therapy, an INR would be between 1.5 to 2.5, so that's 1.5 to 2.5 times longer than what it would take a normal person to initiate the extrinsic pathway. And this would mean that it is also 1.5 to 2 times the control. So we don't worry about patients like this. Sometimes they may even take their patients up to 3 times. The doctor or physician may want them a little thinner than normal. Now, very simply on this, what we don't want to see is we don't want to see an INR 5 times or 6 times or 9 times. That would say that they do not have enough clotting factors in play, and they're taking way too many anticoagulants. We worry about things like a bleed for patients like that. D-dimer screen. A degradation process of cross-linked fibrin, and this is used to diagnose several things, and it tells us something very generic and very non-specific. We use it for abrupto placentae, DIC, DVT, and pulmonary embolism. So what this test gives us is it gives us the ability, and every reference may be a little different on this, or what they consider to be a clinical finding. The D-dimer screen very simply says that you have the ability to facilitate clots. Now, the higher it gets, the greater increase in that ability that you have. So an example of this, let's say that you think that a person has a pulmonary embolism. Well, the D-dimer screen would simply say, yes, they have the ability to clot, and it's a little over rambunctious. The PE, though, would probably be diagnosed by a VQ mismatch and a positive CAT scan. The D-dimer just adds to the clinical picture. Chemistries. The tests often run in panels that contain similar information. They include things like electrolytes, renal function, glucose metabolism, lipid metabolism, cardiac enzyme and markers, and then liver function tests. This is going to be the start of the electrolyte series, and first of all, we're going to talk about sodium. Sodium is essential in anything that we would do that would require energy. Sodium-potassium pump being an example of this. It measures the sodium level in the system. Now, with low sodium levels, we would see a decrease in action potentials, possibly. Normal in this is 135 to 145 milliequivalents per liter, and this is both in the male and female. High values, dehydration, we've thinned it out too much. Excessive saline administration, exchange transfusion with stored blood, or impaired liver function. Don't have the ability to pull back the cations that they actually need. Low values, overhydration, sodium loss, vomiting, diarrhea, sweating, GI suctioning, increased renal sodium loss. So our kidneys are just kicking out tons and tons of sodium. Diuretics, diabetic ketoacidosis, Addison's disease, and renal disease. And these would be from hormonal difficulties, and some of those with Addison's, with renal disease, just your kidneys are in failure. DKA would be secondary to the acidosis and the fluid offload. And then diuretics are generally potassium depleting, but they can have a loss of sodium. Water is going to follow sodium. Electrolytes continue. This is potassium, measured serum potassium levels. Normal in this is going to be 3.5 to 5.5, and this is both in male and female. High values, renal failure. Your kidneys eliminate potassium. Excessive potassium replacements. You've taken one too many slow K or low K potassium replacements. Massive tissue damage, because this is an intracellular residing electrolyte, or associated with metabolic acidosis. Now, whenever we become acidic, what's in the cell generally tends to come out. We get a shift of things. So very simply, as we correct the acidosis, we should watch their potassium levels again. Electrolytes, this is on potassium. Low values could be caused from diuretics, inadequate intake of potassium to begin with, large steroid doses, also associated with metabolic alkalosis. Chloride, measured serum chloride, normal of chloride levels are going to be 100 to 108 milliequivalents per liter, and that's both male and female. High values, increased sodium level. Sodium chloride likes to get together. Decreased bicarbonate levels, or HCO3 levels, or renal failure. Low values are caused from vomiting, gastric suctioning, diarrhea, or diuretic use. Bicarbonate, aka bicarb, HCO3 or aka bicarb, measures serum bicarbonate. Normal should be 24 to 30 milliequivalents per liter. Good number to remember, especially now it would be the venous sampling of it, but we'll see similar numbers whenever we come to the ABG sampling, and that's later on in this series. High values would be too much base excess, or metabolic alkalosis, or loss of gastric contents, or diuretic use. Low values, base deficit, we don't have enough base. Metabolic acidosis, and we've used all of our bicarbonate up. Bicarbonate loss, or increased serum chloride levels. Magnesium. Measures magnesium. Normal on this is 1.4 to 1.9 milliequivalents per liter in both male and female. This is calcium, 9 of 11. Measures serum calcium. Normal on this is 4.3 to 5.3 milliequivalents per liter, male and female. Now, these two electrolytes are kind of at odds with one another. Calcium increases contractile force in our muscles. High values on the calcium, false rise due to dehydration, hyperparathyroidism, malignant tumors, immobilization, thiazide diuretics, vitamin D intoxication, low values, hypoparathyroidism, chronic renal disease, pancreatitis, massive blood transfusions, severe malnutrition, false decrease due to low albumin levels. And we have to have an appropriate amount of protein. Albumin is a large contributor to our protein in our serum, so if we don't have enough albumin, we can get fluid shifts and electrolyte shifts associated with it. Magnesium is the opposing force, if you will, for calcium. It would displace the calcium at its initiating points. Now, calcium in two spots, not only does it initiate the contraction, especially in smooth muscle, but also calcium rushes into the cell to elongate the contraction, especially in the heart where it's more efficient. Potassium measures phosphate. Normal on this is going to be 1.8 to 2.6 milliequivalents per liter, male and female. High values, hyperparathyroidism, calcium, potassium, calcium and phosphate, all adjusted by the parathyroid gland. Renal failure, increased growth hormone, vitamin D intoxication, those would all give us high values. Low values, hyperparathyroidism, diuresis, malabsorption, malnutrition, carbohydrate loading, and antacid abuse. Anion gap measures the difference between anions and cations in the blood. Anions, things like chloride and bicarbonate, all are negative. So whenever we think about both of those have a negative charge in there, and that's what an anion means. And then cations, sodium, potassium, calcium, are all cations. The anion gap is figured sodium plus the potassium minus the chloride plus the bicarbonate. And this would be the anion gap. Unmeasured anions in the serum form a gap. When anions and cations are compared, phosphates, lactates, ketone bodies, organic acids, normal anion gap is 12 to 14 milliequivalents. Increased gap indicates acidosis. Increased ketone bodies and ketones are very acidic. Lactate, which would be the building block for lactic acid, and then organic acids as well. Decreased gap indicates alkalosis, increased bicarbonate, and decreased acids. Renal function test. BUN measures the blood urea nitrogen level of the blood. Normal value for a BUN is 8 to 15 milligrams per deciliter, and that's both male and female. Since this is eliminated, and without elimination from your kidneys, you'll have an increased blood supply of it. High levels, renal disease, renal damage, dehydration, shock, and shock that would cause renal disease. CHF, for congestive heart failure, GI bleeding, or high protein diets. Low levels, overhydration, or increased ADH or antidiuretic hormone secretion. Creatinine measures blood creatinine levels. Normal value should be 0.6 to 1.4 milligrams per deciliter. In women, 0.6 to 1.1 milligrams per deciliter. High values of creatinine would say that a person had kidney disease or have nephrotoxic medications, or medications that would be toxic to the kidneys. Low values, low muscle mass, and muscular atrophy. BUN creatinine ratio measures the BUN creatinine ratio in the blood. Can help determine the cause of non-normal values or abnormal values. Normal value, male and female, should be a 10 to 1 ratio. Now, the BUN should be about 10 times more than the creatinine in the system. So that's where the 10 to 1 comes into play. Ratio greater than 10 to 1 means that you have an external renal disease of some sort, or something that caused renal disease. Causes on this could be decreased renal perfusion, and this could be caused because of shock. Increased urea load, treatment, hydration, obstruction removal if we have any kind of obstructed bowel, or Foley catheterization, so you can eliminate the BUN and creatinine from your system. Ratios less than 10 to 1, meaning you also have renal disease. Causes on this could be chronic renal failure, so this didn't just onset overnight. Decreased urea load, inhibited creatinine secretions, or dialysis has just occurred. Treatment in this, cease administration of nephrotoxic medications, and dialyze. Basic metabolic panel, or BMP. BMP is BUN creatinine ratio, sodium, potassium, chloride, bicarbonate, and glucose level. It's actually loaded into a specific pattern. Whenever the doctors whenever they write this out, make a fishbone of it. So this is the fishbone, sodium, potassium, always in the front, chloride and bicarbonate in the second, BUN and creatinine in the third, and then glucose trails the end, or is the fishtail. References for this section, Part 2, were taken from American Academy of Orthopedic Surgeons, AOS, American College of Emergency Physicians, ACEP, Critical Care Transport. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.